Hello, everyone. Welcome to the webinar on ICD-10. I see from the attendee list that I know a number of you and others I've not had the pleasure of meeting. For those of you who don't know me, my name's Patricia Dean, but everybody calls me Pia. And I am a healthcare attorney at Holland & Hart. I've been here for more than 25 years, a little bit alarming to say. I specialize, as I said, in healthcare law. That includes everything from transactions, but I also have a particular interest in billing systems, FDA, life science, and research issues as well. So we start the new era of ICD-10 tomorrow, as you know. I know that it's daunting and a little bit frightening. I was on a conference call yesterday dealing with the testing results from the most recent CMS testing of the new system, and also talking about dire predictions. And there are many dire predictions out there, as I'm sure you all are aware, but no one really knows what's going to happen because we've never done this before. We've never tried ICD-10. I am heartened by the fact that Europe and other countries have been using ICD-10 for more than 25 years, and that we can get there, but I know that it's a difficult time for everyone involved. The most recent results from testing show that the most recent testing in July, which was the third such testing period, there were also testing periods in January and April, 1,200 people, 1,200 different groups were selected to participate. 493 of those were return testers. I was part of two groups that were doing the testing program. In the July 29,000 and change test claims were received. Of that, more than 25,000 were accepted. That's an 87% acceptance rate. 1.8% of test claims were rejected due to invalid submission of ICD-10 diagnosis or procedure codes, and 2.6 were rejected due to invalid submission of ICD-9 codes. So, and I'll tell you, my group, we purposely put in some invalid codes to see what kind of results we'd get back and the kind of rejection notices we would get. So we suspect that it's a higher than 87% acceptance rate. But again, I anticipate that there's going to be confusion tomorrow. There's been a lot of talk about a blackout period of 90 days or more, or a shutdown of the system on October 2nd. Again, CMS is indicating that they don't think that's going to happen, but I don't think any of us know how that's going to go. So with foreboding and concern, let's move forward. I considered not doing a seminar on ICD-10 because there's so much information out there, so many materials and the like, and CMS has been pretty good about sending out lots of information. I decided to do it, however, because I was getting so many questions from clients that had specific issues with ICD-10 coding and the like. And then when the guidance came out in July from CMS that was very, very confusing, I started getting more questions and decided that it might be a good idea to do a day of kind of seminar just to give a reminder to folks and allow you to ask questions of me. So please always feel free to call me anytime that you have questions or need help. I'm glad to try to answer questions, and we have the ability to ask questions here by text. I will look at those at the end because I can't, I'm not smart enough to be able to talk and read questions at the same time. So I'll take those at the end. And with that, why don't we get started? That's my contact information. Like I said, everybody calls me Pia. You're more than welcome to do so, and feel free to call me or contact me anytime. The agenda for today, I keep having to remind myself why we're transitioning to ICD-10 and that there really are good reasons for doing so. Thought I'd go over those real quickly just to keep our a stiff upper lip and keep us moving forward. I wanted to talk about the basic characteristics of ICD-10, not because I don't think everyone knows them, but because it's easy to forget little nuances, and I thought just covering them. And again, I'm basing this on questions I've been receiving from clients over the last 3 weeks, and some of them are pretty basic questions that just need a little bit of a reminder. I wanted to go over the clinical modification codes and the procedure coding system so that you're very clear on ICD-10-CS and ICD-10-PCS. I want to talk a little bit about ICD-10 in practice, the impact on CPT and HCPCS codes, as well as definitive diagnoses. That's been an issue for several of my clients, and I've had a chance to talk with Dr. Rogers, the ombudsman, about some of those. Thought we could cover that real quickly. I wanted to spend some time on the recent guidance from CMS regarding the one-year suspension of some audits and be sure that everyone is clear what that guidance entails. And lastly, I wanted to do some talking about the GEMS, or the general equivalence mappings that we're using. I'm finding them very helpful in some ways, and that they also have limitations in others. So I wanted to give that a quick discussion. So just a quick reminder, I know this is the very, very basics, but ICD-10 is the abbreviated way of referring to the International Classification of Diseases 10th revision. And the CM refers to the clinical modification, and the PCS designation refers to the procedure coding system. As you guys are well aware, the clinical modification system or clinical modification codes are diagnosis codes, and the procedure codes are exactly what they say, procedures. ICD-10 CM contains more than 68,000 codes. That's nearly 5 times as many as are in ICD-9. That speaks to the complexity of the new system, the specificity that's built into ICD-10, and it is both problematic in that so much specificity is requested, but it is also going to allow us to do some pretty amazing things in terms of tracking diseases, injuries, and the like. So, is the pain really necessary? Like I said, I keep coming back to this. There really are good reasons to do it, and as I've played more and more with ICD-10 and gotten more involved in the testing, I'm reminded that there are good reasons to do it. A reminder, we're the last country with a modern healthcare system to adopt it. ICD-10 was accepted by the World Health Organization in 1990, and most European countries are now toying with going to ICD-11. So it was probably time for us to do that. That's sort of a policy reason. More importantly, our current system, ICD-9, is 36 years old, and it uses lots of outdated and obsolete terms that are inconsistent with current medical practice. And one of the big issues is that the structure of ICD-9 limits the number of new codes that can be created, and many of the categories are full. So as you are likely aware, because some categories have run out of room, a number of the newer codes are in illogical places, or places where you wouldn't expect them. And it can really cause problems when you have a new issue walk into your office or into your hospital that you haven't seen before, or that is not on your supercode list, and you have to try to find it, and then you find it in some place that you, where we didn't expect it. I just got a note that we have lost audio. Joanne, can you hear me now? Apparently not. Luke Kelly is our administrator. Luke, someone has lost audio. Can others hear me still? And Cindy just let me know that she can hear, but she lost. I'm very, very sorry about that, guys. Please let me know if it happens again. Okay, so we were just talking about the fact that many of the ICD code categories are full, and that's been a huge problem. And then ICD-9 produces very limited data about patients' medical conditions and hospital inpatient procedures. I think the idea with the electronic medical record and so many best practices attempts made to change billing systems and, in fact, services provided, the new information will provide lots of information. I have become a believer that that is going to help us in lots of ways down the road if we can survive the transition. I've given you the list of reasons listed by DHHS, Department of Health and Human Services. I put it in quotes so that you don't think I've completely drunk the Kool-Aid, but I do think that there are a number of these things that are true. We will have an enhanced ability to conduct public health surveillance. I am seeing a huge advantage in research efforts and those of you who are involved in research either in a hospital or a clinical practice, I think that you'll be pleasantly surprised by how much more information is available through ICD-10. It also will allow us to do greater comparisons on mortality and morbidity, especially since now we can look at things like blood alcohol levels that will be coded in directly. And lastly, it's going to help with designing payment systems. I mentioned that I'm interested in payment systems. I'm working on projects involving bundled payments and the like. And so hopefully this will help us create systems, bundled payment systems for providers that will not put too much risk on the provider or not allow them to accept too much risk and allow them to be paid appropriately. So that kind of thing is very helpful. The one downside of the specificity of ICD-10 is that it's going to allow recovery auditors and the like to mine data for fraud and abuse issues. And so they're going to have a much greater breadth of information and the ability to mine for fraud and abuse practices, misbilling concepts and the like, so that if anything is, if they find widespread patterns, I think we'll see an increase in fraud and abuse audits. So just be aware of that. It's an ongoing issue that we're all dealing with, I know, on a daily basis, and is a cause of great concern. Real quickly, who's affected? It affects, ICD-10 affects all HIPAA-covered entities. That means everyone who currently is affected by HIPAA will go through the conversion to ICD-10. It affects providers. I've mentioned therapists because I know there's a couple therapists on the line, payers, clearinghouses, and billing services. We also have a couple of those on the line. So if you deal with HIPAA, you're going to have to deal with ICD-10. One of the earliest questions I got was, knowing that HIPAA applies strictly to electronic transactions, can we avoid it by doing everything in paper? And the simple answer is no, because CMS thought it would be way too burdensome on the industry to use ICD-10 in electronic transactions and ICD-9 in manual transactions. They put a mandate that everything, electronic or manual, be done in ICD-10. So ICD-9 is now, or as of tomorrow, will be obsolete, and all claims going forward with dates of service of tomorrow or dates of discharge of tomorrow going forward must be in ICD-10. The effective date, just mentioned it. Anything, a date of service on or after October 1 must be submitted using ICD-10 codes. If the claim is being submitted for a date of service in September, use the ICD-9 code. So it is the date of service, not the billing date, that is the driver as to which code system you use. No claim can contain both ICD-9 and ICD-10 codes. We've tried it. That seems to be the #1 thing that will kick you out of the system the most quickly. So that's no dual coding. The date of service for hospitalizations is the date of discharge. That's been the source of some confusion. So I just wanted to give you a quick example. Let's assume that you have a patient who you've seen in a period of September 30th through October 2nd, either in a clinical setting, outpatient setting, or inpatient setting. For the outpatient visit, you'll need to submit 2 claims. The services performed on September 30th will be submitted on using ICD-9 diagnosis codes, and services performed on October 1st and 2nd will be submitted using ICD-10 diagnosis codes. If you take that same patient and put them in the inpatient arena, if the date of discharge is October 1 or after, you're going to submit only 1 claim form, and that will be using ICD-10 codes. Now, please remember that ICD-10 diagnostic codes are simply that, diagnostic codes. For those of you in the clinical or outpatient setting, you're still going to use CPT and HCPCS codes for physician services. Any claims for dates of service after October 1 that contain ICD-9 codes will be rejected. It's amazing how quickly that spits out of the system. I tried that back in January quickly just to see how quickly that occurred, and you get a rejection notice as well as a reason for the rejection, just indicating that an ICD-9 code was used. Let's talk about the clinical modification codes. These are used to document diagnoses only. The ICD-10 CM codes will be replacing ICD-9 CM volumes 1 and 2. That's very important. So if your life is spent in volumes 1 and 2, you're going to be using ICD-10 CM. The new codes in ICD-10 CM are 3 to 7 characters in length. The first character, the first digit, is always an a letter. The second digit is numeric, and digits 3 through 7 are alpha or numeric. One thing that I've checked is alpha characters do not need to be case sensitive, or they're not case sensitive, so you can use a capital or a lowercase letter. And then there's always a decimal after the third character, always, in ICD-10 CM. As I mentioned earlier, there are 68,000 ICD-10 CM codes. By comparison, in ICD-9, the diagnostic codes were 3 to 5 digits in length, and they numbered only about 14,000. So we have upped the specificity and complexity of the coding system by fivefold. A complete list of the ICD-10 codes are publicly available. I've given you the website there. I'm sure you're already well aware of it and have been in that system. But I do think that the index and tabs for the new ICD-10 are an improvement over ICD-9, especially since there's more logic now that there's plenty of room in ICD-10, so you're going to find things where you most likely will expect them to be. Turning to the procedure code system, ICD-10-PCS, is a procedural code set used for reporting inpatient hospital procedures only, all right? So only for hospital inpatients are you ever going to use ICD-10-PCS. It'll be replacing ICD-9 CM Volume 3. So if you spend your life in Volume 3, as I know many people do, you're going to be dealing with ICD-10-PCS. All of these codes are 7 characters in length. The first character is alpha or numeric and is the initial descriptor. So I've given you there the categories. Interestingly, the 0 code is medical and surgical, and 62,000 of the 87,000 codes are all in that first category, the 0 category, medical and surgical. So most everyone is going to spend a lot of time in the medical surgical code system, and it's obviously highly defined within there, but that is all the medical and surgical codes. And by comparison, the ICD-9-PCS codes were only 3 to 4 numbers in length and only totaled 4,000. So we have even more dramatically upped the PCS codes. And one reason why is because of the specificity involved, side of body, female versus male, but also things like blood alcohol level and blood type. All of those things can now be coded in. And while it's burdensome in the coding system, it does provide amazing amounts of information that you will have at your fingertips going forward. Just a quick reminder, really important, the transition to ICD-10 does not change the use of CPT or HCPCS codes in any way, shape, or form. CPT and HCPCS codes will continue to be used to report services and procedures in outpatient and office settings. So, while ICD-10 codes have expanded detail, including specification for laterality, for some conditions, you should continue to follow CPT and CMS guidelines when reporting modifiers. So as you know, when currently using CPT and HCPCS codes, you use a modifier for laterality to identify whether it's right side, left side, or bilateral. You don't have to do that in ICD-10, but you'll need to continue to use those modifiers in CPT and HCPCS. Let's go over some of the characteristics of ICD-10. There are several new features that are interesting. First, we've already talked about laterality. I've given you a couple of examples. I specifically put in the C50.511, which is breast lesion, to show several aspects of ICD-10. For one thing, that is the specific code for a malignant neoplasm of the lower outer quadrant of the right female breast. What's different about ICD-10 from ICD-9 is that this provides the place of the lesion, as well as which breast and that it's female. So that's the kind of level of specificity that's involved. I've also given you an example of bilateral or a decubitus ulcer of the right elbow. Stage 2, that's another thing that that ICD-10 is, I think, improved upon our staging of various conditions. Secondly, there are now combination codes for certain conditions and commonly associated symptoms and manifestations. For instance, K57.21 is diverticulitis of the large intestine with perforation and abscess with bleeding, a condition commonly seen in the hospital. It gives you that level of specificity. So it's the large intestine with a perforation, with abscess, and bleeding, all within that code. Next, combination codes for poisoning and associated external causes. As you know, we had various modifiers that dealt with poisoning, or I shouldn't say modifiers, I should say supplements that dealt with poisoning and the like. Those are now in the main body of the ICD-10 codes. T42.3X2S is poisoning by barbiturates, intentional self-harm with sequela. So that's the kind of information that is, people are, especially the CDC and researchers are trying to get their hands on, that deals with someone who's attempting to commit suicide, has sequela from poisoning, and that they use barbiturates to attempt to kill themselves. The character X is an interesting issue. It is used as the 5th character placeholder in certain 6-character codes to allow for further expansion. So the very problem that we have with ICD-9 not having enough space, they've built into ICD-10 space for additional expansion. So you'll see X used as a character holder, but you can also see it to fill an empty character space when a code that has that is less than 6 characters in length requires a 7th character. So let me try to explain. If you are dealing with a code that is going to have a 7th slot, there is something in the typical 7th slot in a family of codes, but there's nothing in the 6th slot, you put an X into the 6th slot so that the 7th character doesn't slide into the 6th spot. I hope that makes some sense. If you have any problems, let me know. But we'll also go over a couple of examples that I think might be helpful. Other characteristics of ICD-10, the obstetric codes identify trimester instead of the episode of care, which is different from ICD-9. So, for instance, 026.02 is excessive weight gain in pregnancy's 2nd trimester. So that, that level of specificity for trimester is now included. Also, there's an inclusion of clinical concepts that do not exist in ICD-9 CM, things like underdosing, blood type, blood alcohol levels. Mentioned that briefly earlier, but we now have the V67.40 is type O blood, Rh positive. There's another code for blood alcohol levels of varying degrees, each one having a different code, or I should say ranges. Next, there are a number of codes that are significantly expanded. This includes injuries, diabetes, substance abuse, postoperative complications, and some things dealing with behavioral and mental health. F10.182 is alcohol abuse with alcohol-induced sleep disorder. I just put that in to show the level of specificity that you can now code for. So if you have a patient who is not sleeping that you believe is due to alcohol rebound or some sort of alcohol-induced issue, there is a specific code for that. Again, oh, and the next code that I put in, the T82.02XA, the A refers to the prosthesis. The X is a placeholder in the 6th spot, so there's no character to go into that 6th spot, but you use an X there as a placeholder so that you can get to the A, which has to do with the heart valve. I hope that makes sense. Again, if it doesn't, please let me know. Other characteristics. Injuries are grouped by anatomical site, rather than by type of injury. That's a change and I think an improvement. Because of restructuring in many categories and codes, the classification of certain diseases and disorders are different from ICD-9 CM. So that really speaks to our increased sophistication in medicine, our greater understanding of diagnosis and the like. So for that reason, that makes all of your lives a little bit more difficult because some things that were in old categories that you're very used to are going to be in new categories. But I do think there is logic for most of them. Also, certain diseases are reclassified in different chapters or sections to reflect current medical knowledge. Again, sort of the same thing I was just discussing. You will find certain things in different chapters now based on advances in medical understanding and clinical information. And there are new coding definitions involved. So you're going to find some things that are different from what they used to be. An example is the definition of an acute MI is now 4 weeks rather than 8 weeks. So they've halved the acute period. And then the other thing I wanted to just mention, just so that you know where they are, the V codes and E codes, which were supplementary classifications. These always stood for factors influencing health status and contact with health services. That was a supplementary classification. It's now in the body of ICD-10. Likewise, the E codes, which were external causes for injury and poisoning, as I mentioned earlier, the poisoning used to be a supplemental code. It is now in the body of ICD-10 with its own specific family code. I've gotten several questions about use of nonspecific codes, and while you guys may already know this well, I just wanted to cover it real quickly for any of those who might still have lingering questions. Nonspecific codes are still very much available for use when the documentation you have doesn't support a higher level of specificity. So obviously CMS, CDC, and others are pushing for the greatest level of specificity possible. But there are times when that just simply isn't the case. So ICD-10 contains many more, or still contains non-specific code sets that will allow you to use when you don't have enough information. But it also contains many more codes for signs and symptoms than ICD-9 and is better designed for use in ambulatory encounters when definitive diagnoses are often not yet known. So I do think that the non-specific codes are still very much available, are fairly easy to use, and we'll go through an example. Just real quickly, when sufficient clinical information is not known or available about a particular health condition to assign a more specific code, it's acceptable and in fact preferable to report signs and symptoms or unspecified codes that accurately reflect the healthcare encounter. So let's just take, by way of example, a not uncommon situation. A patient walks into your clinic who is complaining of chest pain. Obviously concerning, the differential diagnosis includes everything from acute MI to pneumonia to a ton of other things that you guys know much better than I. The question is how are you going to code that encounter, especially if you decide that that patient needs to go immediately to an emergency department and be seen for serial troponins or an EKG and the like. The answer is twofold. You can do it a couple of ways. There is a non-specified unspecific code for chest pain, which is R07.9, and that is chest pain unspecified. You can also code it for signs and symptoms. So if that same patient comes in and says, I have chest pain, and upon questioning indicates that they have pressure or tightness, there is a specific code for pressure and tightness. They both actually have the same, which is R07.89. So as I said, it's very helpful to be able to code just for signs and symptoms. Do not feel like you need to run additional diagnostic tests to code with more specificity. The unspecified codes are very, very appropriate, and in fact, CMS has gone out of its way to indicate that it's inappropriate to run diagnostic tests or assume a more specific diagnostic code unless the medical records indicate that specificity. Similarly, what to do about external cause code reporting. Similar to ICD-9-CM, there is no national requirement for mandatory ICD-10-CM external code reporting. unless you're subject to a state-based external cause code reporting mandate, or these codes are required by a particular payer, you are not required to report the cause codes found in Chapter 20, the external causes of morbidity. In short, if you haven't been reporting external cause codes under ICD-9, you won't need to do so under ICD-10 unless a state or payer-based requirement is instituted. So nothing about this transition changes your requirements for external cause code reporting. So with that, let's go to the most recent guidance. I think it's telling that on July 7th, CMS issued a guidance regarding certain flexibilities that was so confusing it then had to come out and issue a clarification of the guidance. And I read the guidance when it first came out and thought, okay, I think I get it, but I'm not entirely sure I got it. And then I got a dizzying number of questions from clients and realized I didn't understand it well enough either. So I was very pleased to hear that the clarification of the guidance had been issued. I've given you cites to both. I think it's also telling that the guidance itself was just a couple of pages, and the clarification of the guidance is a question and answer format, and it's multiple. It's I would say by a factor of 4 times as long as the initial guidance, but it does help. The first thing that I heard is that people thought that the new guidance would be yet another delay of the implementation of ICD-10. It is not. And there's good reason to think that, or perhaps hope that ICD-10 implementation would be pushed off yet again. It's been delayed 3 times in the last 5 years, and there is still legislation in the United States Congress dealing with delaying ICD-10. But the guidance had nothing to do with the implementation date. So again, we're going live tomorrow. I don't think that there's anything happening in the legislative branch today that's going to change that. I think that going live is inevitable tomorrow, and we should all be prepared for that. Just a quick reminder, if your claim is rejected for any reason, follow the existing procedures for correcting and resubmitting the claim. The guidance doesn't change that aspect either. While CMS will ultimately require coding to the greatest level of specificity, what the guidance says is that for 12 months after the implementation of ICD-10, so from tomorrow through September 30th of 2016, if a valid ICD-10 code from the appropriate family of codes is submitted, Medicare fee-for-service will process and not audit valid ICD-10 codes with a few exceptions. That is a mouthful, and that is unfortunately what the guidance said, and it takes a little bit of unbundling to figure out exactly what it means. I think that the examples are very helpful in clarifying exactly what the guidance says. Let's go back and talk about what we know about ICD-10 CM codes. The first 3 characters are the family of codes. So as we mentioned, for chest pain, it's R07. That would be the family of codes for chest pain, or the category heading, if you will. And that may be further subdivided by the use of 4th, 5th, 6th, or 7th characters to provide greater specificity. So taking on an example, Hodgkin's lymphoma is in family code C81, which by itself is not a valid code. So I don't want you to think you can ever say, I don't know more than this patient has Hodgkin's lymphoma, and I'm just going to call it a C81 and submit a claim that way. You can't do that. Valid Hodgkin lymphoma codes within category C81 contain 5 characters. So for this particular family of codes, they all contain 5 characters. C81.00 is nodular leukocyte predominant Hodgkin's lymphoma of an unspecified site. You can see what they are for C81.03, C81.10, and C81.90. The most general is C81.90, Hodgkin's lymphoma, unspecified site. So that is the most general. And you must use one of those codes for Hodgkin's lymphoma if you're coding for that disease. What the guidance says is that during the 12 months after tomorrow, using any one of these valid codes for Hodgkin's lymphoma will not cause an audit under CMS's recently announced guidance, or what they're calling their flexibility. So if you do not know any specifics about a patient with Hodgkin's lymphoma, you can bill any one of those 4 codes, the C81.00, the C81.03, the C81.110, or the .90, and it will not trigger an audit. All right? I hope that makes sense and is very, very clear. If you have the level of specificity to say it's a .10 or a .03, great, but if you don't, for the next year, you can use any one of those codes and it will not trigger an audit. Taking another example, and I wanted to use this one because it involves a varying number of characters. So let's go to Crohn's disease, case 50. Case 50 is considered the family, the code family, and it is one that has varying numbers of characteristics. So case 50.00 is Crohn's disease of the small intestine without complications. .012, so it's now a 6-character code, is Crohn's disease of the small intestine with intestinal obstruction. And K50.90 is Crohn's disease unspecified without complications. To include the Crohn's disease diagnosis on a claim, a valid code must be selected. So again, you can't use just K50 or even K50 decimal. You have to use either the 00.012 or the .90 for it to be a valid claim. But if you use any of those, any valid claim, if it's paid and selected later for audit, the guidance says that the claim would not be denied simply because the wrong code was included, so long as you use the correct family and they are in the same family. So if you have a Crohn's patient and you put in a chest pain code, that will not work and that will still trigger an audit. If, however, or if you use a K50 and nothing after it, that also is not a valid code. But if you use one of the valid codes, then you'll be safe for the audit for the next year. The idea of this was to give smaller practices some leeway and a little bit of a cushion to get used to the coding specificity. Likewise, you could not use a K50.08. That's not a valid Crohn's disease code, and therefore that will not work and will trigger or could potentially trigger an audit and denial of payment, just so that you're clear. There are some exceptions, as you probably heard in that general discussion of the guidance. It said some, and those exceptions deal with national coverage determinations and local coverage determinations, NCDs and LCDs. The guidance from CMS does not change coding specificity required by NCDs or LCDs. As a result, a claim may be denied because the ICD-10 code is not consistent with policies specified in an applicable NCD or an LCD. So you need to follow pre-existing instructions for coding specificity required by LCDs and NCDs. I know that some LCDs are already trying to correlate to the current ICD-10 system, but not all. So it's always a good idea to refer to the complete list of LCDs and NCDs. I've given you, obviously, the website for that, and I'm sure you're well aware of it. There are some limitations on the CMS guidance. Again, in that middle section of that slide, I've given you the exact language that they use. The guidance specifically states that for 12 months after ICD-10 implementation, Medicare review contractors will not deny physicians or other practitioners' claims billed under the Part B physician fee schedule through either automated medical review or complex medical record review based solely on the specificity of the ICD diagnostic code, so long as the physician practitioner used a valid code from the right family. Okay, we've just tried to unbundle that, and I hope that I've helped in that and certainly not hurt. The key, or one of the keys, is that the guidance pertains only to Medicare fee-for-service Part B physician fee schedule claims, right? It does not apply to Medicare Advantage. It doesn't apply to other capitated systems. It applies only to Medicare Fee-for-Service Part B. It also refers to Medicare review contractors. One of my first questions was, what does that include? And that includes pretty much everyone you can imagine, the Medicare administrative contractors, recovery auditors, zone program integrity contractors, and the supplemental review, medical review contractor as well. So that's the definition of that. Other limitations. The Medicare Fee-for-Service Audit and Quality Program flexibilities pertain only to post-payment reviews. So if you are submitting a claim for pre-approval or prior authorization, it will not have this same leniency. You have to use the exact specific code that will be required. So the leniency, the guidance does not apply to prior authorizations or prepayment reviews. The CMS guidance applies only to Medicare fee-for-service claims and does not apply to claims submitted for beneficiaries with Medicaid coverage that is either primary or secondary. So again, only Medicare, not Medicaid. And likewise, and this is a biggie, commercial payers are not obligated to observe the one-year period covered by the guidance. Each commercial payer will have to determine whether it will offer similar audit flexibilities. And that's an ongoing debate between some of them. My advice to you is, unless you've received specific notice from your commercial payer that they will observe the one-year no audit leniency, the safest approach is to assume that all claims are potentially auditable and not subject to the leniency provided for in the guidance. And the caveat, of course, is that the leniency does not apply if there's any evidence of potential fraud. So this guidance has nothing to do where your audit is related to potential misbilling or billing irregularities that a RAC may consider potential fraud and abuse. So what do we do during this time frame? What do we think is going to happen starting tomorrow? My biggest fear is that accounts receivable are going to extend considerably. I think the financial implications beyond just the cost involved in implementing ICD-10 are what we're going to see in terms of backlogs of claims and accounts receivable. Some people are saying accounts receivable could go up by 30 to 45 days. More realistic claims, I think people are saying 10 to 20 days. But in any case, it could cause a real cash flow crunch for your particular clinic, hospital, or the like. CMS says it's conducted extensive testing. I've looked at the results of the testing. It does look pretty good. Then again, it's always been on a limited basis, and what happens tomorrow is going to be harder to anticipate. So I want you to always remember that there are advanced and accelerated payments possible. If a MAC is unable to process claims within established time limits because of administrative problems, advanced payments may be available. So I want to remind you that Section 42C2 of the Social Security Act requires Medicare contractors to make payment on not less than 95% of its clean claims within 30 days. In other words, all MACs are shooting for a 30-day turnaround on claims. They're required to do 95% of clean claims, that being claims that don't have issues, but in fact they are always trying for 100% within 30 days. An advance payment is a conditional partial payment which requires repayment by you. So it is something that you will have to repay whether or not the claim is ultimately accepted and paid. But advance payments are available. There are multiple conditions around receiving advance payments. Those can all be found at 42 CFR 421.214. If you need a copy of that section or have questions, please don't hesitate to contact me. I didn't put them all in here because I think that it's a very good idea to refer to the section since the physician practitioner has to submit a request to his or her MAC specifically about a case. So I think the best approach is to take a look at CFR 42.214 to look at the conditions for allowing for advanced payments. But I am working with at least 2 clinics which will be going for advanced payments because of concerns that their margins are thin enough that they're concerned that cash flow crunch is inevitable, and they're taking steps to avoid that. I also want to talk about the issue of dual eligibles and Medicaid crossover. This is another area where I have enormous concern about how this thing is going to work. Dual eligibles, of course, are folks that are covered by both Medicare and Medicaid. State Medicaid programs are required to process submitted claims that include ICD-10 codes for services furnished on or after October 1st in a timely manner. And that's all that the reg says, is in a timely manner. Most states are prepared for the new requirements and will deny claims based on system edits that indicate a diagnosis code is not valid. So most state Medicaid programs are ready to spit out an ICD-9 code with a date of service of October 1st or later. But as we all know, not all states are created equal. Not all state Medicaid programs are created equal or funded appropriately. And so there's been some real issues. CMS has stuck to the line that each state is working with its Medicaid managed care organization to ensure it's ready to receive and process ICD-10 claims. But I think it is somewhat telling that CMS has granted 4 state Medicaid programs an extension during which they can use a hybrid ICD-10 and ICD-9 code. That tells you that at least 4 states know that they are not ready to implement a full ICD-10 system. So in those systems, they're allowing you to use a hybrid where you can use ICD-9 or ICD-10 codes. Again, I'm very, very worried about a backlog or a delay in payments for those. And by the way, the 4 states that are the extension has been granted for include California, Louisiana, Maryland, and Montana. And I know that at least one of you is from Montana. Actually, I see a couple of you, I think, are in Montana. And so that's an issue for you. It is, since we have 50 different Medicaid programs in this country, each state being very different and very unique, I think it's best to approach your state. CMS has an interesting website that I've given you the site for there that allows you to hover over the state that you're interested in or the state that you're in, and it'll then take you directly to that Medicaid site and indicate its readiness. Again, these sites aren't created equal. I've taken a look at some that I think are very good. I've taken a look at others that give me great pause and great concern. So if you have a large dual eligible population, I would urge you to work with your state Medicaid office in Colorado at HCPCS, or Healthcare Policy and Financing is our state Medicaid agency. Talk to them about their readiness and what they're anticipating in terms of delays and the like. And then the last thing I wanted to cover, of course, subject to what you guys have questions about, is general equivalence mappings. I've been using these a lot, and I found them to be helpful. I went into it with a little bit of skepticism about how good they were going to be, and I found them to be better than I anticipated. But they work better in certain situations than they do in others. As you may know, GEMS, as we call them, were created by CMS and CDC to ensure consistent national data. The CDC took the position that if they were pushing so hard for ICD-10 because they are anxious and very excited to have the greater specificity and all the information that ICD-10 provides, that they should also help make sure that we're all using the same language, and the GEMS are intended to do that. They're available in the public domain free of charge. I'm aware of at least 2 groups that tried to sell general equivalence mappings. They just put it out there on the web, and they were shut down very, very quickly. Needless to say, CMS did not take kindly to that attempt to make money off of things that should be free of charge. So you can get those easily. They're available. As I mentioned, they function as a translation dictionary between ICD-9 and ICD-10 so that everybody is hopefully using codes in the same way, especially when it comes to social determinants of health, housing. There are lots of things in ICD-10 that we've never been able to code for before, which tell us about food insecurity, housing insecurity, and the like, that we hope will improve population health over time. It's especially important for the FQHCs. So the GEMs are an idea, try to get us all on the same page for purpose of using the same codes. I've also found them very useful for superbills. Many practices and facilities create superbills that contain the most common diagnostic codes used in their practice, and converting a superbill to ICD-10 can be accomplished by going through the code book, but it's also often a great place to start using the GEMs. That's how I've used them the most and found them to be quite helpful. There are some limitations, however, with GEMs, like with most everything. Please remember that they were not developed to provide help in coding medical records. That's not really what their intended use is. Mapping is different than coding. Mapping only leaks concepts into code sets without consideration of patient medical information. So they're not looking at the patient that you are. They don't have a specific person with signs and symptoms and the like in their office. And unlike mapping, coding involves the assessment of the most appropriate code based on the medical record documentation and applicable coding rules and guidelines. So coding still is different than mapping, and I urge you to remember that if you are using GEMs a lot. I know I was working on a specific issue and relied on the GEM a little too heavily and decided there was one way we should go. And then when I went back and took a look at the medical documentation, thought, no, that's the difference between mapping and coding. So I think they're a great starting place and a good translational tool, but also be sure to double check. I do think this will all become second nature for us. The question is, second nature in a week, a month, or a year. I'm hoping that it all becomes second nature sooner rather than later for everyone's wherewithal and well-being, I guess I should say. Just a reminder that GEMs are best used to convert the following databases from ICD-9 to ICD-10, specifically payment systems, payment and coverage edits, risk adjustment logic, quality measures, and a variety of research applications involving trend data. The GEMs are very, very helpful in the research realm. Since those of you involved in research, either clinically or at an academic medical center or in a hospital, the transition to ICD-10 during the middle of a research project is a little bit daunting. The GEMs are particularly helpful, I think, in that arena. That just about concludes what I wanted to say. I just wanted to remind you a couple things on financial implications. In February last year, the AMA published a report that I've read, and I'd be glad to send any of you if you'd like to see it, that small practices can expect to spend anywhere between $56,000 and $226,000 in the transition to ICD-10. That includes software, training, and lost productivity. Obviously, everyone has spent a lot of time changing over this. We don't have enough coders in this country who are really good at what they do. And so there's been some, at least in Colorado, there's been some cherry picking or some headhunting of very good coders. All of it has caused a lot of angst and the like. So there has been a real cost associated with the transition and out-of-pocket cost. To give you some context, most of the small practices I've seen have been around $100,000 or a little bit under. I have not seen anything in the $220,000 or even anything in the $200,000 range for the transitional cost. But it is a real cost. In addition to the training and software and lost productivity and all of that, there is this whole issue of cash flow crunches that continue to cause me the most angst, and I suspect many of you the same. I think the most considered opinions are that they expect accounts receivable to increase by 10 to 20 days. I think the 90 days is worst case scenario, but that's going to continue to be an issue, and we'll have more information as of tomorrow. And then also, I just want to keep reminding you that with the increased specificity in ICD-10, there is going to be lots of meat for the RACs to perform sample surveys, looking for general errors that could lead to widespread improper billings. Remember that they're paid on a contingency fee basis. They're out there looking for a small problem that could have wide-ranging ramifications for purposes of bringing an action. So always stay vigilant when it comes to fraud and abuse issues and anything that could lead to a False Claims Act issue. Just a reminder. Something else to keep you up at night, I'm afraid. Lastly, I just wanted to give you a couple of resources. The CMS named Dr. William Rogers as an ombudsman for specifically for the ICD-10 conversion. He's an emergency room physician, very, very nice man. I've had the chance to talk to him once and his staff a couple of times. He's a doc, he understands, he gets it. He is also part of CMS. He's the director of the Physicians Regulatory Issues team. I think a strong advocate for providers, and he understands the angst and the difficulty of making this transition. He'll be working out of the Coordination Center in Baltimore, and that opened in September. They're more than willing to help manage and triage issues, he and his staff. I am not sure how large his staff is, but I know I've talked with a couple of different people. And the way to reach him is by email, and I've given you a link to his email there. And then the last slide is just other potential resources. If you have specific questions, you can also feel free to shoot those to me, and I can hopefully get you to the right place. My closing thought is to remind you that breathe, take deep breaths, hang in there. Everybody's in the exact same boat. And I think that lots of people are around to try to ask questions and try to solve problems, and we'll see what happens. I do know that there are several legislators who are saying if this thing crashes and burns, there really is a blackout, and the system crashes not unlike .gov did, or healthcare.gov did for the Affordable Care Act. People will be putting forth legislation to do a fix. Hopefully we won't need that, and things will go relatively smoothly. But keep breathing, call with questions and the like. If I can give any assistance, I'm glad to. And then there's a couple of questions. So we're right at the end. So one of the questions is, as you pointed out, C50.511 is a very specific code for malignancy in breast. However, if we biopsy a mass lump or calcification, it seems to me that N63 is the code for use for biopsy of mass, and that seems quite nonspecific. Please comment. I agree with you. I have only briefly looked at the N63 codes, and the way that the one system that we've dealt with this has done it is to enter the C50 code, specific code for place in breast and laterality of the breast, and then use the N63 code for the general biopsy. Other than that, I can't give you a lot of comment. I've not played enough with that particular coding issue. Sorry if that's not much help, but I agree with your assessment that the N63 is a more generalized biopsy of mass. Let's see here. I think there's other questions. Let me see if I can quickly do these. Kaylee asked for a copy of the PowerPoint presentation. Of course, I think it was sent out to you earlier today, but I'll be sure that you get a copy of it. And I believe that is all the questions that we have at this point. I know we're right up against the hour. Thanks, you guys, for attending. I appreciate it. I'm sorry if the information has been remedial, but hopefully some good reminders. And as I said, if you have specific questions, please always feel free to contact me anytime. I'm glad to try to help any way I can, and hang in there, everybody. Thanks, you guys. Bye-bye.